HPV virus is really what we call endemic now to our society. It's pretty much everywhere. And really the thinking is that 80% of us get infected with this virus. You know, the good news is that most of us clear it. The vaccine is there really to protect those patients or those people who are unable to clear the vaccine.
This is Anthony Effinger. I'm the host of the Think Neuro podcast at Pacific Neuroscience Institute. And today I have one guest with me, Dr. Vivian Wu. She's an otolaryngologist, also known as a head and neck surgeon. Tell us about your background, your education, and how you got interested in this field.
Yeah. Well, I'm from the DC area, outside DC. Maybe was interested in medicine early on, but really kind of cross country to get away from my mom. Went to Cal Berkeley for undergrad and kind of, studied science, was a molecular cell biology major, but hadn't really, dedicated myself to like, all right, I'm gonna do the pre-med track. So I took kind of the long route to get to med school. I did a public health degree in the middle. I spent.
What did you imagine when you were an undergrad? Were you thinking research or just was it interesting?
I worked in a research lab. I think I was just a baby at the time.
Yeah.
As I started as a 17-year-old, and
Wow.
I mean, I'm so jealous of the gap year concept now because I probably should have taken one.
Yeah,
but,
me too.
Whatever. It was a good time. I probably would have appreciated Cal Berkeley more if I was older when I was there.
Yeah,
but
same.
It's all right.
Yeah, I think yes. So then you did a public health degree?
So I did a public health degree. So that was 2 years. I did a couple years in a lab, actually.
Where was the public health degree?
At Yale.
Wow. Okay. Did you go straight from Berkeley to Yale?
I did a couple years in the lab first.
Okay.
I was doing some
Right.
Gene therapy work, and then moved from there to. I was really thinking to myself at the time. I like human interaction. I'm a pretty talkative and social person, and so and then sort of learning more about public health, and so did that public health degree. My roommate at the time was a med student. Of course, it's always like, oh, grass is greener. So then the application started.
When you're at Yale.
Yeah.
My wife works a little bit in public health. It's fascinating right now, especially. I imagine
going on or not going on, I guess we should say. So it's a tough time. It's a little bit scary.
Yeah.
I think sometimes it's hard to know now what data is out there that's actually reasonable and true and usable and shareable. So we just have to read lots of sources and hopefully get to the right one.
Is that your strategy now? Yeah. Yeah. Okay. So after public health.
So after public health, I started med school.
Where was that?
Back in DC, near home, at Howard University. So it was great. I mean, I loved med school.
Yeah. Okay. And then what's the training for head and neck?
So, head and neck surgery is usually a 5-year residency.
Yeah.
You go through all the way. You're chief as a 5, so you're automatically a chief when you're in your 5th year. I did a couple extra years in the lab because I just really like doing lab work. I always thought to myself, hey, we're doing a lot of downstream work in terms of surgery, chemotherapy, and radiation. But if you can figure out the biology up front, maybe we could figure, end cancer, of course. We're not there yet, obviously, but so I spent a lot of years in the lab, 2 years during residency, and then even during fellowship, which is at Michigan, I spent my 2nd year there in the lab. So
fellowship describe what a fellowship is.
So residency is otolaryngology training in which you learn about ears and nose and throat, like all the things that go along with ENT, which is another sort of moniker for what we do. In fellowship, you're very focused on, you get yourself more siloed. So for me, I did head and neck oncology, which means that I'm studying cancers of the head and neck that develop in the head and neck, and then how to operate on those patients, how to manage those patients. And then, of course, all the, meeting with all the other, not only supportive oncology, but the other specialties that manage oncology, right? Radiation oncology and medical oncology. Those folks are very close. We all work together, basically, to create this village for the patient.
So when somebody says they're fellowship trained, it means they've got
additional training beyond your residency.
Yeah.
Right. So to become really a doctor, you should go through a residency. You don't have to do a fellowship.
Right.
But for the fellowship is just additional training so that you, are really up to date on the latest and greatest that you can do for your patients.
Yeah, totally. So what makes the head and neck what unifies this as a discipline?
So the head and neck is I know it's sort of, you hear head and neck, you hear ear, nose, throat. There's a lot of functionality that occurs that that is, let me say. So when you're talking about ear, nose, and throat, the ear has functions that lead that result in sometimes problems in the nose, or vice versa. If you have a stuffy nose, you sometimes get a plugged ear. So there's a lot of sort of nooks and crannies and passageways that go between the ear and the nose and the throat, which sort of unifies that, in addition to the fact that we are around and doing surgery around what's called the cranial nerves. So we've got 12 cranial nerves. They're large named nerves that come out of the skull base and spread out in the head and neck region.
Okay.
And so our specialty is very well versed in how to find those nerves, protect those nerves, and make sure that they're safe after the operation.
I see. You don't handle anything in trigeminal neuralgia, do you?
Well, generally that is something that might come to see us, but that's the wheelhouse of the neurosurgeon.
I thought so.
Yeah.
That's a terrible.
It can be
terribly
very,
painful
very
thing.
debilitating.
Yeah.
And it's super fascinating how it can happen. Sometimes it's one blood vessel that's pumping and like rubbing on something the wrong way that makes that, like the nerve, that makes that nerve hurt. So it's like, it's a real sleuthing exercise to try and figure out what is happening in this scenario.
We've talked to your colleagues about that. It's just fascinating. So how long have you been at PNI?
I've been at PNI since December 2024.
And so where were you before?
Prior to that, I was at Henry Ford Health in Detroit, Michigan.
Okay. So you moved from Detroit to Southern California.
I sure did.
That's a move.
It is a move.
Yeah.
I've been to California before, Northern California for undergrad, and that's really where I fell in love with the state.
All right.
So,
What does your week look like here?
So the week is, I'm building this practice. That being said, the group has really provided me with all the tools I need to have a full running clinic. So I've got a couple of clinics, one in Santa Monica on Wednesdays, and then another in Burbank on Thursdays. Mondays and Tuesdays are usually reserved for operating, and then Fridays are kind of administrative / if you have a emergent case that you need to add on, we'll try and get that on. And St. John's has been very accommodating for getting patients in that need sort of these types of urgent surgeries.
Okay.
There's different kinds of surgeons, right? There's surgeons that do predominantly elective care. In oncology, it's almost never necessarily elective. I shouldn't say that. There are elective cases.
Yeah.
But again, in oncology, the elective part is really how anxious is the patient, and I'd like to alleviate that anxiety if I can.
Yeah. Thank you. When doctors say clinic, I like to define that, because I think people think clinic is like you go to the clinic and you get, some penicillin, but that means you're seeing patients and not doing surgery.
Correct.
Right.
Correct.
Okay. All right.
I still wear scrubs to clinic.
Okay.
That's also a choice, I guess. People get real dressed up.
Is that a Detroit thing, or?
No, it's a me being lazy thing. But in clinic though, so basically you're seeing patients every 15 minutes. We have a great
At your level, you are too.
Well, yeah. I mean, you want to see as many as possible, so that as many people can get in and get the answers that they need from.
You sound like my primary care friends.
50. I know. Well, so if you ask my patients, it's never 15 minutes. If they need 45, it's 45.
Yep.
And so unfortunately, the next patient, might have to wait a little bit. But everybody gets the time that they need.
All right. And so Mondays and Tuesdays are?
Mondays and Tuesdays are OR days. And Wednesdays and Thursdays
what
are
do those
clinic
look
days.
like?
Generally, we Mondays are reserved, and this is so Mondays are reserved for the big combination cases. So what does that mean?
Yeah.
For head and neck cancer, we're sometimes doing cases that require a pretty big resection of a cancer, let's say on the tongue or in the voice box. If you can imagine you're taking out a piece of somebody's tongue, you have to reconstruct that. And there's not enough local, you can't just take part of the cheek and and reconstruct that. And so what we will sometimes do is what's called a free flap. You take a piece of tissue from another part of the body, from the arm or the leg, and you reconstruct that defect that I've created. Now that, when I say combination, I don't do that part of the surgery. My partner, Dr. Kochar, does that. And so we work very closely together on many, many cases to provide this care for patients.
So Dr. Kochar does the removal from elsewhere?
So I do the removal of the cancer.
Right.
Dr. Kochar will then take a free flap donor site, so whether it be the arm or the leg or other places, and reconstruct the tongue with that piece of tissue.
Wow. And
Pretty intricate
the
work.
term flap, you're just talking about a piece of muscle, right?
Talking about a piece of muscle with sometimes with skin,
Okay.
but always with a blood supply. So it comes with a artery and a vein. And what we do, it's called a free flap because we disconnect the artery or vein from the distant site, the arm or the leg, and then we reconnect it back into the arteries and veins in the neck. And so there's always two sites that we're working on. The head and neck, of course, is one, and then some alternate site where we're trying to find fresh tissue to bring in.
Nothing complicated about all that.
No, it's very intricate work. So
Yeah, I can imagine. How long is your average surgery? I mean, is that a question that's possible to answer?
So those surgeries take the combination free flap surgeries take minimum 8 hours, at times 12, depending on how complicated. Sometimes we need to reconstruct bone too, and in those cases we actually take parts of the fibula, which is actually a bone that can be transplanted, and patients still walk.
Why? Because it's redundant, or because
This is a great question for Dr. Kochar. It's not that it's redundant, but folks can still manage to walk very easily. And I've even had a scenario where I heard of a marathoner afterwards, which is a little bit. I know that's a little bit. I probably wouldn't recommend that.
Okay, fine.
But people will do what they want to do.
Doing fine. Okay, so what are the cancers that you see in the head and neck?
My practice as a head and neck surgeon is broken up into 3 components, really. And I've been very fortunate that a third of it is mucosal disease, which are the advanced tongue cancers, throat cancers, tonsil cancers, inside the mouth and throat. The second third would be skin cancers. And so any skin malignancy that develops in the head and neck, whether it be the scalp or the ears or the face or neck. And finally, my last third is more of an endocrine practice. And endocrine surgery encompasses thyroid diseases such as thyroid nodules, thyroid cancers. But about a third of my practice is what we call mucosal disease, or disease inside the mouth and the throat. So things like tongue cancers, cheek cancers, tonsil cancers, voice box cancers. So that's about a third of my practice. Those
Caused by
usually caused by so there's 2 different avenues here. Many of our patients have smoking and drinking as their primary cause of cancers, but the other side of things is the HPV-related cancers, and those are sort of an epidemic in our world and on the rise. And so,
Why is that?
Well, so HPV virus is really what we call endemic now to our society. It's pretty much everywhere, and really the thinking is that 80% of us get infected with this virus. The good news is that most of us clear it. So with our natural body functions, we clear it. But there's a good 10 to 20% of us that do not. And so we don't know how to find who those people are. Who are the ones who clear it and who do not clear it.
Okay.
So you may have heard about the HPV vaccine. The vaccine is there really to protect those patients those people who are unable to clear the virus. Yes.
So my kids got the vaccine.
Perfect. So they will likely be protected from being infected and having a latent virus floating around in the lining of.
And if I got the vaccine.
So the FDA
You're already out in the world.
Yep. So the FDA has approved the vaccine up to age 45. There is controversy even for that 27 to 45 age group, and people getting it after age 45.
Why?
Now this is the reason I believe for. I think I'm okay with it. I'm actually a proponent for having that vaccine at a later stage. The reason is because majority of the HPV that's floating around, the virus, is a subtype called 16, maybe also 18. But the vaccine currently is a 9-valent vaccine, which means it covers 9 different subtypes.
Okay.
And so there are 6, I said there were 2, so 9. There are 7 other subtypes that you're protected from that are not as common.
Okay.
And so you certainly could be protected from those subtypes when you're getting the vaccine at a later age. You're right. You should be getting the vaccine before you're ever exposed, which is in the early years, 9 to 11 years old to 13 years old. But if you're getting it later in life, I do believe that vaccine is helpful for protecting from those other subtypes.
Okay. And you exposure, how do you get this?
So this is considered a sexually transmitted disease, but really is some thinking that even deep kissing leads to it, right? I mean, again, 80% of us get this, are infected by this virus at some point in our lives.
Yeah. Wow.
So it's out there.
It's out there. Yeah. Okay. So and that's you're seeing more of those kinds of cancers.
Absolutely. HPV related oropharynx cancer is actually the most common type of HPV cancer we talk about something called incidence. How many new cancers are come up a year? There are more new cases of HPV-related tonsil and base of tongue cancer than there are of cervical cancers now. So there was everybody kind of knows about cervical cancer and how HPV, how HPV causes cervical cancer. But in 2010, there was an inflection point, and there's certainly much more. There's more HPV-related tonsil cancers now than cervical cancers per year.
Yeah, in Portland, I know of 2 people who have died from HPV related.
That's very unfortunate.
Yeah, they look like us.
Right. I mean, there is some good news with HPV, although not for maybe the 2 that you know. HPV related disease is generally very responsive to therapy. They do better. So we actually have split up from a staging perspective, the HPV positive tonsil and base of tongue cancers from the HPV negative. And the reason is because they behave very differently. HPV positive disease is a very good likelihood you'll be cured from it with what we can give you. HPV negative, it's harder to say that. The 5-year survival rate is more along the lines of 60%, whereas for HPV positive, it's more along the lines of 85 to even 95%.
Oh, interesting. With what therapies? Are we talking surgery?
So surgery and radiation, chemo. It's a little bit dealer's choice, and it a little bit depends on each patient, okay? How does your anatomy fit? How big is your tumor?
Yeah.
Where is the tumor going? So there's a lot of things. It's not just one size fits all for this. That's why you really need an educated surgeon and medical oncology and radiation oncology team to think about, hey, is this a possibility that you can have surgery? Because if you don't have surgery, then you can still do chemo and radiation.
Okay, right. The notion of viruses causing cancer is fascinating. That's
it's a whole nother
podcast,
absolutely.
Or 3 or 6 or series. But needless to say, this is on the rise, and
it absolutely is on the rise.
We should probably ask for our viewers, like, what do you start to notice first when you have an HPV cancer?
So the most common presenting symptom is a neck mess. So like sore throat, yes, maybe. Trouble swallowing, yes, maybe. But I think 80% of my patients come in, doc, I got this thing. I've been on 2 rounds of antibiotics. It's not going down. And to me, for a 40 to 70-year-old white male, that is cancer until proven otherwise. I would need to work that up, thinking along the lines of cancer.
40 to 70.
Absolutely.
70. What happens at 70?
40 to 90.
Okay. All right.
40 to 90.
All right. Yeah, I got you. And then there are a large number of cancers of the head and neck that are skin cancer.
Correct.
Right? I bet you those are going up too.
Absolutely. So another third of my practice is skin cancers of the head and neck. The head and neck is the most exposed area of your body. You're out in the sun, et cetera. Frequently we see things in spots that are just not easily noticed if you're just looking in the mirror, back of the ear frequently, right? So people talk about, make sure you put your sunscreen on the back of the ear. Yeah. It's important because this is absolutely exposed, but one that's very difficult to see if you're looking in the mirror. And so, these facial lesions are generally caught. People are looking, again, in the mirror all the time.
I am.
Yep. But whether, if it's sort of to the side, on the ears, on the scalp, trickier, harder to find. Yeah. I've had several cases where hairdressers have found cancers and alerted their clients, and then they come to see me. I would love to shake the hands of those hairdressers, really thorough evaluation, and even saying something. Sometimes I think it's tricky in that scenario to say something to a patient that's, that looks concerning.
Right, and your hairdresser, kind of, you're out of your lane.
It's you're out of your lane.
But hey,
please do it.
That would be a great public service
Absolutely.
campaign. I mean, really.
Absolutely. Okay.
I mean, that could be a really great first line of defense. And I'm sure hairdressers would be, on board, right? I don't know.
I don't know.
Yeah, we don't know. Well, you have a degree in public health too,
I
so
do.
you can do this. No, seriously.
I'm along the same lines of you of thinking that yes, it should be a common thing. But I don't work in their world. They don't work in my world. So it's they have clients that have a certain relationship with. You never want to mess with that.
Yeah. Well, I mean, it's a good argument for having a kind of a personal relationship with your hairdresser, right? And
Absolutely.
You want somebody to say something. On skin cancers, there's various kinds. Melanoma is the one that gets all the attention because it's
well, so melanoma is the
deadly,
sneakiest.
Yeah, sneakiest.
It can spread to lymph nodes more commonly.
Is that what makes
and it's also the deadliest when it gets to that stage. We get a little bit more nervous. We up the amount of treatment that the patient is offered. But yes, melanoma is the one that certainly gets the most press. But the most common that you see is a basal cell cancer. Those tend to not spread to lymph nodes, but they are found everywhere. And, you've got folks who have been in the sun quite a bit. They're like, yeah, I had this one burnt off or that one frozen off or this one cut off by a Mohs surgeon. Those generally tend to be basal cells or even small squamous cell carcinomas. So we've now talked about basal cell carcinoma, squamous cell carcinoma, melanoma. The fourth and more rare type is a Merkel cell carcinoma, seen more in the elderly, over 80. That's actually caused by a virus too, if you can believe it. I know it. There's a bunch of viruses out there.
Great.
Sneaky little suckers.
Wait.
So, but the first three are generally due to sun exposure.
Okay. Isn't there research on I feel like I've seen some encouraging signs on melanoma or some treatments.
Oh, so immunotherapy is probably something that everybody's at least heard about.
I think that's what I'm thinking.
Okay. Immunotherapy's first successes were in the melanoma patients, and they have really radically changed the way we're able to not only treat, but I don't know if I should use the word cure yet, but really prolong life for patients who have advanced melanoma. It is sort of a miracle, how poorly some of the advanced cases did 10 years ago or 15 years ago before we had immunotherapy options, compared to how they are sometimes essentially cured these days.
In the last decade.
Absolutely.
And I assume you're using these treatments.
We are.
Yeah,
so we are,
sure.
The sequence of how we were using them, for the very, very advanced cases, generally those people up front go and get immunotherapy. But I think for melanoma and squamous cell, we still attempt to do surgery first and then treat with immunotherapy afterwards. There has been some movement towards switching the order of that. One of the reasons is immunotherapy needs to kind of see. So immunotherapy is there to boost your immune system. Okay. Let's say you're to take out a cancer and the immune system was seeing the cancer, but the cancer is now gone because it's been cut out. Okay. The immunotherapy that then you give afterwards is boosting the immune system, but the immune system doesn't have a cancer to necessarily look at and build upon.
Yeah.
So the new thinking, and this is still in mostly clinical trial phase, but I think it's percolating out there that we can potentially use this as a hopefully standard of care someday, but to do what's called neoadjuvant immunotherapy. Immunotherapy up front boosts the immune system while the tumor is actually still on the patient's body. The cells are seeing the tumor. They are boosting to that particular antigen or whatever it is that they're fighting.
Yeah.
And they're able to really develop a more robust immune system, immune response to that very specific tumor. And then after we allow that to happen for up to 6 weeks, if there's anything remaining, we then go and cut that out.
Yeah.
Surgery is always available. We can always have surgery. But this is a very, very interesting, I think, approach because it really uses the biology of not only the tumor, but the biology of how the medicine works for you.
Certainly.
So,
immunotherapy, is that bespoke to, it's tailored to your immune system?
Exactly.
Exactly.
It is utilizing So they're called PD-1 inhibitors, which are the different sort of markers on cells that in the scenario of tumors sometimes get suppressed, but in the scenario of a immunotherapy, they kind of allows those markers to kind of come out again and be present on the cell so that we can use that mechanism to kill off the tumors.
Okay, that's a terrific description.
Yeah, it's the best I can do.
No, that's terrific.
Going back to the thyroid aspect of my practice, much of endocrine surgery and thyroid surgery revolves around thyroid cancer, or trying to diagnose a thyroid cancer. And sometimes it requires a surgery to do that. We have great genetic testing now for the thyroid, but it's not perfect. And so let me just throw out an example. We have a patient who might have a single thyroid nodule that's 3 centimeters, maybe identified incidentally, like a patient had a car accident and had a CT scan that showed a thyroid. The next step is using an ultrasound, and then we needle biopsy that to identify what it is. Frequently, that biopsy will come back as undetermined or unknown significance, and so we send these off for genetic testing. And in those scenarios, they might tell us, hey, this is most likely a cancer, or we're still not sure. And in that scenario, I would be involved in helping to operate on the patient, take out half the thyroid usually. If the thyroid nodules on the right side, we'll do a right-sided thyroidectomy. If there's nodules on both sides, we have to have a longer discussion about whether or not we need a total thyroidectomy or not. For sure, if a patient's diagnosed with thyroid cancer, I worked very closely with their endocrinology team, with the nuclear medicine team to first do the operation. So thyroid cancer is still a surgical disease in the sense that we would want to clear as much of the disease as possible and then leave the rest to the nuclear medicine team and endocrinology team to provide radioactive iodine or whatever management medically that needs to happen afterwards.
When you say you're building the program, say more about that. What is that?
Yeah, so St. John's is a really a storied program from a cancer perspective. We've got
right across the street here, right?
right across the street.
We're at P&I.
Yeah, we're at P&I.
St. John's is a big hospital right over there.
Correct.
Okay.
Correct. St. John's is a hospital that I do probably 50 to 75% of my cases at. So St. John's has a cancer institute. The initial surgical therapies and how we manage melanoma surgically came out of St. John's Cancer Institute from Dr. Donald Wharton, who's just a legend. And you mentioned that to anybody who works in melanoma, they're going to know Dr. Wharton.
But he was right over here.
He's right over here. He was a surgeon. And what's fascinating is that, you hear about clinical trials, you hear about, those types of things. Those are frequently run by medical oncologists. It's very rare to find a surgical trial where you have multi-centered clinical trials coming together with thousands of patients to demonstrate that this surgery helps. Okay. Surgery is very, you put an IV in, you give medicine. It can kind of be sort of across the board. Yes, we can look at things, but surgery depends on not only the patient, but also the surgeon. So there's just more factors involved.
Oh, sure.
Harder to do a clinical trial. Yes, more variables involved. Harder to do a clinical trial when it comes to surgery. That being said, we're still trying. There's actually, I've been involved in 2 or 3 surgical trials recently, which we love to see. But when you look at the sort of the list of maybe one institution versus another, how many clinical trials they're doing, probably there's 2 surgical ones and there's 50 medical trials going on.
That's fascinating. I did not know that.
Yeah,
but it makes sense.
Yep.
So he was doing.
So he
did that.
So Dr. Morton really established how we surgically manage melanoma.
That's why St. John's is this
storied institution.
And you're next door, and you can
correct.
And there must be resources and institutional knowledge.
Absolutely,
right?
Absolutely.
Yeah.
They have an incredible tumor bank where they've collected particularly melanoma cases to study in the lab.
A tumor bank.
A tumor bank, yes.
That means.
So
I'm picturing like a room full of
you should picture a room full of minus 40 degrees, 20 degrees, or 70 degree freezers full of little vials with
That's what it is.
individual patient samples in them.
I thought you were going to say there would be pictures and digital information, but no, we are talking analog.
We're actually
little
talking
files.
about tissue.
Wow.
Okay. Now, hopefully that tissue is used and then for analysis from a DNA, RNA,
Yeah.
protein perspective.
Okay.
To study, how how did this patient respond to their treatment, or how, what does this look like after we've done this to it? So there's different ways to look at that tissue.
Yeah.
But you say, is it digitalized? Well, that's the goal, is to get that tissue,
okay.
study it to death,
yeah.
throw that data into the computer, and hopefully have a bank in which now a data bank in which we can sort of mine and make sure that we
Turn
can see
AI
what we-
loose on that.
Yeah, that would,
Maybe.
Yeah, that would be.
I've heard-
incredible.
Yeah, I was talking to somebody who was saying they think that's going to be AI. We think AI is going to do all sorts of things, good and bad, but we'll see.
Yeah.
Okay, so that's a real asset over there.
Absolutely. So building the program for head and neck is really trying to bring all the pieces together. And when I say pieces, I mean teams together.
Yeah.
So for example, let's just say we talked about melanoma a little bit, but my head and neck cancer patients who have the tongue cancers and tonsil cancers, they do actually require a lot of resources. So if you can imagine, if you have a tongue cancer, that's a very painful scenario, number one.
Oh, God, it's gotta be,
Your
right?
tongue is in your throat.
Yeah.
It's for speaking. It's for eating. It's for breathing. It's for swallowing. And now you have a cancer in there.
And the vocal cords are this.
And the vocal cords are just there, right?
Multifunctional, wildly complicated.
Absolutely.
Yeah.
So all of that is so critical to just, like second to second function. Okay. And now it's compromised. Okay. So these folks really do require a lot of resources from a support side. So to build a program for a head and neck cancer patient, I first need to make sure I have the right radiation oncology team. I have the right medical oncology team. We've got the surgeons in place that are able to do the most advanced care. For example, we have a single port transoral. We have a single port robot that helps us to do surgeries, which is not
does that
something that
mean?
you find
Single
all
port?
over. So robotic surgery is something I think
Yeah.
most people have heard of
Yeah.
now.
Of course, where prostate surgery.
Prostate
with the,
surgery,
the Da Vinci
gynecologic
machine.
surgery.
Yeah.
Yes, it's the Da Vinci machine. But prior to probably about 5 years ago, you would need to put 3 different instruments into the mouth. I mean, 3 different ports in the mouth, and then an instrument would come out
Port
of that
being
port.
like
So like you would have 3 like metal
Yeah.
like tubes kind of going in, so that we can then pass our robotic
Okay.
instruments
Yeah,
that are
yeah,
mobile
yeah.
in your mouth to work. The single port, which is just a new variation of that tool, but it's a refined variation, only has 1 metal thing that goes into the mouth, and then within that metal tube, there's 4 instruments that deploy.
Wow.
So those 4 instruments are actually deploying within the mouth. You really shouldn't even see them at all. So it just allows more. You can even have a smaller mouth and work with.
So one of those
Work
would
with a
be,
single port.
Would one of those be a microscope?
One of them is a camera,
Camera.
and then the other 3 are instruments
Yeah.
that you can work with, whether it be to pull things or to cut things
Yeah.
or to cauterize things. So it's very cool. And that skill is not necessarily found at every single hospital across the country. Okay, so the community hospitals aren't going to have everybody who's able to do that. In our LA area, certainly we have different groups that can, but here at St. John, we also have one. Okay, so again, you want the surgical team, you want the radiation team, and the medical team really to be up to date on the latest and greatest trials and treatments for your patients. But on the flip side, or not even flip side, at the same time, you need a lot of supportive care for these patients. So I have every one of my patients see a speech language pathologist. That's a speech and swallow expert, because again, we talked about this is speech and this is
Swallowing.
And as you go through, whether it be surgery or whether it be radiation or whether it be adding chemo on top of it, people's functionality on that respect changes and needs to be rehabilitated after we're all done.
Oh yeah.
So our speech language pathologist is critically important to helping our patients get through this process. We always refer to a dietitian, because your diet will change as well. You may need to eat soft foods. You may go down to even just a liquid diet. But our dietitian is really one to kind of check in with the patients weekly as they're going through treatment, seeing where they are in that treatment. If they're having more trouble, We sometimes even need to think about, gosh, do we need to bypass the mouth altogether and put a temporary feeding tube or nose feeding tube in for patients? So we have a dietitian that also sees all of our patients, and we encourage all of our patients also to see a psychologist who's specializing in oncology. So we call that psych-onc.
You have those.
We do. We do. Dr. Corey Nathan is our sort of resident psych-onc expert.
Psych-onc. Yeah.
And it's, it's a very unique, I think a lot of people out there have therapists and their own psychologists. And if there's a great relationship there, I encourage my patients to go ahead and see those folks. But, when it comes to cancer, there's a certain, there's a different kind of level of anxiety there
100%.
that I think you really need that cancer expertise from a psychological perspective. And so, a lot of my patients tell me, hey, I've got my own therapist. I said, that's fine. That's fine. I just want you to know that this person is also available who really only sees folks who are dealing in that oncologic, dealing with oncology.
I mean, that makes
and
perfect
cancer.
sense.
So
when you talk about building a program,
it's to gather all those pieces.
Yeah, and you've got those, like, what doctors do you deal with mostly here at PNI?
So the doctors we deal with are the radiation oncologists and the medical oncologists.
Yeah.
I also rely on my pathologists. It's so important that I actually know what is the disease I'm looking at. What are the features of the cancer? Because not all cancers are the same. Even a squamous cell, there are aggressive features, and there are kind of like, okay, this is an okay squamous cell. It's not a good thing, but it's better than the one with aggressive features. Okay.
Yeah.
So you need a great pathology team who can identify those things for you. You need a great radiology team. So we've got neuroradiologists and we have people who just look at sort of head and neck radiology all the time to tell me, at that spot right there, you need to make sure maybe when you're in surgery that you go after that because, of course, I'm looking at it too, but it's always nice to hear from somebody else. Make sure to go and look at that. Where these conversations frequently happen is what's called our multidisciplinary tumor board. So all of these people I've so far talked about attend this tumor board, sort of weigh in on each patient that we talk about for about 10 minutes. Okay, what is their swallow function right now, and what do we expect as we go forward? This pathology looks bad. You might want to consider doing this or that or adding something else. Okay, maybe we need to add chemo because the pathology looks so bad. And so radiologists, pathologists, radiation oncologists, medical oncologists. But again, the supportive oncology teams of speech-language pathology, dietitians, and psych-onc are critically important.
Yeah, that makes a ton of sense. Those meetings must be fascinating, by the way.
They're good. They are sometimes very sad because we're talking about pretty advanced cases. Yeah. But those really do generate your brain to start thinking about how can we do things better. That's really, I think, that meeting. If we could do it weekly, is where we really get sort of ideas to how do we make things better for the patient.
Yeah, totally. Yeah, that makes a ton of sense. This is fascinating. I so appreciate your time. We could talk about this for forever. Dr. Wu, I thank you so much for your time.
Of course.
I know you're busy.
Thank you.
Thank you.